This is patient 77774444, prostate fossa alone. I'm going to contour the case of a 73-year-old man who underwent a radical prostatectomy for intermediate risk prostate cancer. At the time of prostatectomy, he was found to have Gleason 4 plus 3 adenocarcinoma involving the gland bilaterally. There was no seminal vesicle involvement, and he had a positive margin at the left posterior lateral prostate. Postoperatively, his PSA went to undetectable, but 18 months later his PSA is now 0.12. So we've decided to go ahead with post-prostatectomy radiation. I should also mention he had a lymph node dissection at the time of surgery and had 26 negative lymph nodes. So I've decided to just treat the prostate fossa alone. So we are here in Eclipse in the contouring workspace. I'm going to go ahead and magnify this a little bit. You can see that dosimetry has already outlined the bladder and rectum. I'm going to turn those contours off because I don't want them to influence my contours for the CTV. I'm going to change the windowing a little bit to make sure my contrast is adequate for this. There we go. So that should be good for drawing our volumes. I like to scroll up and down a lot to identify various areas. The vesicoureteral anastomosis is defined as one slice below the lowermost urine-containing slice of bladder, which I think we're probably seeing urine here. We're probably seeing urine there, and then it disappears. And we should try to shoot for about 8 millimeters to 12 millimeters below that level to make sure that we're encompassing the entire anastomosis. There may actually still be urine there. That's probably one slice below that. But other definitions say that if you look here on the sagittal image, that the PTV comes down to but does not include the penile bulb. So we'll see how that works out when we draw our volumes. So I am going to magnify this yet again. That's maybe a little too much. Magnify this again, and I'm going to start drawing my CTV. Now for me, the CTV comes down in this area and goes all the way to the posterior border of the pubic bone. Comes down and actually includes the levator ani muscles, which you can see on both sides here. And I'm trying to see, I may have inadvertently included just a tiny bit of the anterior rectal wall there. And we'll just keep coming down and entering that same area, giving plenty of margin here. Still see a little urine. And the urine has pretty much disappeared here. And we'll continue coming down, just drawing these tissues just anterior to the rectum here to make sure that we don't miss an anastomotic recurrence, which is a very common area for recurrences. And then our dosimetrist is also drawn in the penile bulb, and we'll use that as a reference. I don't think that this is actually penile bulb here. That's a little I'm not actually seeing it, but that's probably fairly correct. So these are 2.5 millimeter slices. If this is the vesical ureteral anastomosis, I'm going to go 3 slices down to make sure that I include 3 to 4 slices down to make sure that I include. I'm still in penile bulb here, so I've got to get rid of this and go back to CTV. And we'll do one more slice here. I'm going to add a 7 millimeter inferior PTV margin. So that last slice is going to have to come out, otherwise our PTV will converge into our penile bulb. So as we come up here, you see the bladder is getting more and more expanded in the bladder neck here. We'll enter out to these muscles. Continue going all the way anterior to the pubic symphysis and all the way out to these levator ani muscles. And I'm starting to see that my volume is fairly large at this point, so I'm going to start bringing it in a little bit. RTOG guidelines indicate that we should start bringing this in at the top of the pubic symphysis, and that's pretty close to where this is. I think there are some patients that you maybe wouldn't want to go that high. And we want to include an area that includes the posterior aspect of the bladder. Come across this anterior rectal wall, and now we're actually coming out to the obturator internus muscles with our volumes. And we want to go up maybe just a couple more centimeters once we start making our volumes come in here. His seminal vesicles were normal, they were uninvolved. So I really wouldn't bring this all the way up to the remnants of the vas deferens in his situation. If you saw obvious residual seminal vesicles, you may want to encompass them. I don't see anything obvious here. I can see these plastic clips from the robotic prostatectomy. And I'm including just a thin rim of bladder back here in my volume. So I'm going to see where I started bringing it in and see how many slices I have now. I have 1, 2, 3, 4, 5, 6. I'm going to do one more slice, and that'll be just about 2 centimeters from where I started bringing my volumes in. If the seminal vesicles were involved, you would certainly want to go higher. See, these volumes do drape around the rectum. That does increase the rectal dose, but I think all of these tissues back here are at risk in a post-prostatectomy situation. So that's our prostatic fossa. You can see what the normal shape of it on the lateral image here. We treat with a full bladder, or at least a comfortably full bladder, and with we have the patient shoot for empty rectum. That's hard for some of them to do. And now I'm going to add my PTV volume. So here at UCSD, typically so I'm not adding a new volume. I'm just going to create a PTV margin. So I am going to create my margin from my CTV. I'm not going to use a symmetrical margin. I'm going to add 7 millimeters around all of the edges, except for posterior. I'm going to add 4 millimeters. And we'll see what that looks like. So, pretty reasonable inclusion of the anterior rectal wall without treating too much of the rectum here. IMRT will be able to do that nicely. And so you can see my PTV volume comes down and touches, but does not include. So here's my penile bulb. One slice above is where my PTV starts. So as you can see here on sagittal, touches, but did not include the penile bulb. And that should give us adequate margin on that vesicoureteral anastomosis. So when I have a detectable PSA and I'm treating in the salvage setting, I'll give 7020 centigrade in 39 fractions. So I'm going to change the name of this CTV to CTV 7020. Make that a CTV and say OK. Then I'm going to change the PTV by double-clicking on it. I'm going to change the name of that to PTV 7020 and make it a PTV. So that's my contour for my prostate fossa.